it off to Greg to introduce our first set of speakers. Greg? Okay, so it looks like Greg may be having some issues. So our first speaker this morning is Nicholas Masica from Thomas Jefferson University, Perfusion and Extracorporeal Technology. He will be talking today on extracorporeal cardiopulmonary resuscitation from cannulation to home. Welcome, Nicholas.
Hello, everyone. My name is Nick Masiska. I'm a senior perfusion student at Thomas Jefferson University. First off, I would like to thank the Academy for allowing me to present about extracorporeal cardiopulmonary resuscitation, or ECPR. Here's a brief overview of my presentation. I'm going to cover what exactly ECPR is, various cannulation strategies that we have, who and who we should not cannulate, multidisciplinary management, multi-organ effects due to extracorporeal circulation, and also various decannulation options that we have. So what exactly is ECPR? ECPR was first utilized back in 1976, but now is becoming much more widely used in resuscitation. It involves the initiation of veno-arterial extracorporeal oxygenation, that is pulseless cardiac arrest, with the concept of restoring cardiac output, perfusion, and oxygenation to major vital organs. Diagram here shows survival rates as a trend in regards to minutes of low flow, contrasting ECPR and conventional mechanical CPR, which really only can deliver about 30 to 40% of normal blood flow to your brain. Survival rates are much higher from onset of cardiac arrest throughout low flow periods in ECPR, and even though it may not be ideal, ECPR can actually provide for a longer low flow period. Certain cannulation strategies that we have can vary here. Since initiating ECPR usually takes place during high intensity code situations, usually chest compressions going on, lots of moving bodies in the room, etc. Typically, femoral cannulation, or also known as peripheral cannulation, is the most commonly cannulation strategy that is used. Utilizing this strategy provides minimal interruptions in chest compressions, limiting that no flow period of time. And on that platform, once flow has been established and the patient is stabilized, the option to add in a distal limb perfusion cannula off of the arterial line can take place. The most common placement for this distal limb cannula is in the superficial femoral artery, but when and if to cannulate with this technique varies between entities and program protocols. Some programs will place SFA cannulas in peripherally cannulated patients in any situation. All their patients, as just their protocol, they will place them. Other programs, they will monitor oximetry in the legs distal to the cannulation site, and they'll only place the SFA cannula if the site becomes symptomatic. With this femoral platform, retrograde arterial flow will be achieved, and because of this, the patient can run into some issues depending on the functional state of the left ventricle. What we can see is either distension of the left ventricle. In that setting, we would need to place an additional drainage cannula to act as an LV vent to offload the ventricle. Or, on the opposite side of the spectrum, the LV is going to show some recovery, and the patient will actually show signs of what's called a north-south syndrome or Harlequin syndrome. If this is the case, the lungs have still yet to recover to optimal function. An additional return cannula, most commonly placed into the right IJ, can be added, just to be sure that well-oxygenated blood is traveling to the brain. If the cardiac arrest occurs postoperatively with a still open sternum or a freshly closed sternum, the surgeon may opt to cannulate centrally. With central cannulation, the surgeon will most commonly place a drainage cannula in the right atrium and a return cannula in the ascending aorta. Either platform, once we're successfully cannulated, the cannula will be connected to the extracorporeal circuit. As you can see in this diagram, the venous cannula will take blood from the venous system through the circuit to a pump head, which typically is centrifugal pump head for adults and a roller pump head for pediatrics. The pump head sends blood to the deoxygenated blood to the oxygenator. That's where the gas exchange is going to occur. And then from the oxygenator, oxygenated blood is going to return through the circuit back to the arterial cannula into the arterial system for the patient. Optimal flow is typically achieved 3.5 to 5 liters per minute for adults and 120 to 150 mLs per minute for pediatrics, all according just to the size of the patient. Because this is such a new practice and it's still evolving, there are still many areas of uncertainty yet. But what we do know is that the quicker you can achieve full optimal flow, the better chance of recovery for the patient. That, along with the high-stress environments in which these situations can arise, it may be difficult to make split-second decisions. Wasted time discussing on whether or not to cannulate these patients could ultimately be the difference between life and death. But if you have an ECMO program that has predetermined set of absolute indications and contraindications, these can avoid prolonged discussions, and making decisions consistently abiding to these guidelines can lead to better outcomes and lower rates of mortality and morbidity. Other things that need to be considered are proximity to a hospital that has an CPR program for outside of hospital cardiac arrest. Research shows that good functional recovery is more likely if the time of collapse to the start of ECMO flow is less than 60 minutes. On top of that, patients who undergo prolonged conventional mechanical CPR are more likely to experience widespread organ damage, including, but not limited to, brain injury, myocardial dysfunction, and systemic inflammatory response. Also, if known what the underlying cause of arrest was, and if it was a terminal diagnosis, that diagnosis itself should be contraindicative for implementing CPR. Many times the underlying cause is unknown, and placing these patients on ECMO can provide us time for the intensive care team to perform various diagnostic tests to distinguish exactly what caused the arrest, and then we can intervene appropriately. Another question we need to ask is, what was the patient's functional status prior to arrest? If they were completely bedbound with end-stage multi-organ failure, then the need to carry on with life-sustaining measures may not be exactly appropriate. Lastly, we take into consideration what the patient's downtime was. If they had sustained periods of hypoxia, which could likely result in an irreversible anoxic injury, cannulating for ECMO may not be our best option. So here I'm going to talk about some contraindications. As I stated before, there are no universal set of guidelines for whether we should or should not cannulate. Granted, if patients do have a defined do not resuscitate order, this will obviously be imposed as an absolute contraindication worldwide. Similarly, to what I discussed on my previous slide, having baseline neurological impairments could be considered contraindicative for many programs just because their long-term prognosis is not good. Other immunocompromised patients or patients with disease processes that are reversible, such as end-stage renal disease, severe metastatic cancer, severe CHF, etc., may also be reasoning enough not to cannulate, as these patients will most likely not survive the ECMO run. Another contraindication could be severely coagulopathic patients. They are prone to excessive bleeding, or on the opposite end of the spectrum, they'll be clotting off oxygenators and circuits frequently requiring changeouts. As I touched on earlier, prolonged arrest or low flow time can also be a contraindication due to the high risk of brain anoxia and poor long-term prognosis. And also sometimes we have difficulty obtaining access for cannulation just due to a lack of access for patients with peripheral vascular disease and or just anatomical anomalies. This can actually make the decision to not cannulate for the provider at that time. But in the end, it can be incredibly difficult morally to say no to placing these patients on ECMO and allowing them to expire in the moment. But if we create these preset guidelines, it can make these decisions to say no much easier for providers, especially when there's no direct benefit to the patient. Going through these guidelines can ultimately prevent prolonged, drawn-out care and possible pain for the patient, and also grieving at bedside for the families when death is inevitable. So now we've cannulated the patient, the road to hopeful recovery begins. ECMO now provides a platform for the patient to be stabilized and allows us as the team to pursue diagnostic tests and intervene as necessary. ECMO programs vary from entity to entity in terms of who can monitor the patient at bedside. It is common that trained and experienced ICU nurses can monitor these ECMO circuits, but perfusionists should be in-house at all times. Although there are some hospitals across the country that perfusionists are not in-house, but they'll be on call from home at all times. We as perfusionists are the experts, and we must be available to troubleshoot any mechanical issues which will go wrong, and when they go wrong, we need to be able to help resolve them immediately. It is also important that we're continuously involved with the plan of care and collaborate with the ICU team. This heart is going to be continually evolving, and we need to pay special attention to certain things, such as the functional status of the left side, whether it's dilating out and needs to be decompressed, or possibly that the patient is north-southing, like I touched on earlier, and the cannulation strategy may need to be altered. What's the volume status of the patient? Are they underfilled and need some resuscitation, or are they overfilled and need some extra diuresis? Also, do we need to intervene with any pharmacologic interventions? Do they need some contractility support or possibly some afterload reduction? Whatever is best to optimize the patient. As the patient remains on ECMO support, we are most likely going to see effects throughout various organ systems in the whole body. It's critical to obtain a neurologic status as soon as safely possible once we are on extracorporeal support. If there is some sort of traumatic brain injury with no evidence of recovery, the decision to move forward with additional support and care may not be necessary, and further discussion with the family is needed. The heart is going to be obviously changing its function. It's going to be going in one direction or another, so frequent echocardiograms are absolutely necessary. These patients will also be on mechanical ventilation, at least in the immediate post-arrest period. And with that, they can undergo various issues associated with ventilator support. Such things such as pneumonia, barotrauma, difficulty to wean are just a few. And these patients may require temporary dialysis, either because of an acute kidney injury or even sometimes to help correct severe acidosis that they may be in. Risk with these patients that is common is associated with being bedbound for so long. They absolutely need to be addressed. I myself am a CT-CICU nurse for the last several years, and I've seen firsthand the consequences of being in a bed for months on end. This is why it's critical to have turning schedules set in place for your facility. So now on to decannulation. Once some testing and planning has taken place, it is time to figure out what the plan is going forward. This ECMO platform is now being used as a bridge to some sort of destination. The decision on where to go are based off of what the health status is of the patient and also what their long-term desires are. And if they are not of sound mind, the family needs to get involved. ECMO can be used as a bridge to recovery, where the intensive care team takes the right intervention to fix the underlying issue. And if or when the patient recovers, decannulation can be scheduled when hemodynamically stable. ECMO can be used as a bridge to bridge, where the patient will need long-term LV support. So an implantable LVAD can be inserted if appropriate social support is there for the patient. The LVAD can then support the patient until organ transplantation or destination therapy can be achieved, both of what I'll touch on here. Either platform can be served as a bridge to transplantation, where the patient will remain on support awaiting an organ transplant. Or lastly, the LVAD can serve as a bridge to destination, where the patient will live their life as they can until the pathology of the disease will run its course, until inevitable demise will unfortunately take place. And my references. Again, I want to thank you for your time. I hope you enjoyed the presentation.
Thank you, Nicholas, for that great, wonderful presentation. We will move forward to our next talk.